I'm Dr. Raymond Douglas, and really my pleasure to welcome both our patients who are here in person, but also the attendees online. And sometimes it's hard to get everywhere where we travel, including Long Beach, even though it's a great sunny day. So really want to thank everyone for coming. And most of all, I'd love to thank our panelists who are all up here. You're going to learn more of who they are. They're a composition of world-respected surgeons, endocrinologists, physicians, but also advocates, including experts in the financial and care coordination, and patients who are willing to really bravely share their story of what they have gone through and really be open to questions, not only for other patients, but also for the families who are here supporting patients, because that's often sometimes the most difficult thing is to understand this disease through caregivers and families' eyes. And so that's a huge goal for ours today, and hopefully you'll see that, and I know that you're going to love meeting every one of our panelists up here. So these are all of our speakers and guest speakers by name, but I'm going to allow them to give a little introduction. Dr. Gupta will moderate and give them a little introduction as we go along. So we're going to start off with what is thyroid eye disease, and I bet everyone here has their version or idea of what thyroid eye disease is, but it's always good to kind of level set. And we can level set from both a scientific viewpoint, what is thyroid eye disease from a, molecular nature, et cetera, but really probably more importantly, what is thyroid eye disease and how it is seen by both patients and the world around them. And that's probably the more important question. But what we know is that this is a very serious and progressive debilitating autoimmune disease. And by being an autoimmune disease, that is fundamentally shows that our immune system is attacking our eyes and in most cases our thyroid. And it attacks two different receptors in those circumstances. And the autoimmune disease and the autoimmune component often has to be either treated or it can kind of burn out. And we'll talk a lot more about that. And it's most commonly associated with Graves' disease. I think everyone who's a patient probably really understands the difficulty in the thyroid management and the hormonal changes that occur. Our patients are going to kind of talk through their individual experiences and how that happened, but also our endocrinology experts will also talk a little bit more about that too. In general, 80% of people who get thyroid eye disease do so within 18 months of Graves' disease. And this is kind of true because the immune system attacks two receptors, one on the thyroid and one around the eyes, and it tends to do so in kind of a coordinated fashion. So it doesn't mean that people can't get a reactivation or can't get eye disease after many years of having Graves' disease, because I see that all the time. It's just that it is less likely to happen. So if you've had Graves' disease for 10 years and no eye disease, it doesn't mean you're out of the woods. It just means that it's much less likely, at least, to happen. And with many autoimmune diseases, it impacts women at a much higher rate than men. But the really important thing is, when it does affect men, it usually is quite severe for men, usually in much higher rate of vision loss for men and much higher rate of having the need for really complex management and even complex surgery. So men get this disease pretty severely when they do. And the impact, the rate, even in our, in the patients we treat, is about 6 to 8 times more common in women than it is in men. Now, patients and everyone's going to kind of talk about what thyroid eye disease looks like. And the textbooks always say that it has proptosis, which is eye bulging. And sometimes the eye bulging is quite variable, and sometimes it's actually very hard to see, and sometimes it's very, very obvious for patients. Eyelid retraction, which often gives that characteristic stare. And the one thing that's not treated well with medications is eyelid retraction, and that's the one thing that probably bothers them the most when they take photos, because they always have a stare. And that's probably best treated surgically, but it's the telltale sign of thyroid eye disease because it happens in about 95% of patients. And during this course of thyroid eye disease, there's also a lot of inflammation. As you can see, this patient has a lot of eyelid edema, and the skin of the upper eyelid actually becomes thicker in addition to just having fluid. And you can get what's called chemosis, or almost this jelly-like formation on the eye. Many patients will see that. And sometimes these inflammatory processes can result in double vision, because the muscles actually get bigger and they get attacked. The muscles that move the eye actually get bigger and they can't really move. So instead of operating like a rubber band, they kind of operate more like a rope and kind of restrict the eye movement. And sometimes they get so big that they can actually restrict the blood flow to the nerve and cause what's called compressive optic neuropathy, or vision loss. So not everyone gets every one of these. The disease is quite heterogeneous. I'm going to show you some pictures of that. But this is all what can occur, especially on a textbook level. Now, the disease is commonly associated with Graves' disease, not 100%. So about 10% of patients don't have even thyroid problems, so it can occur without that. But what every patient, really with thyroid eye disease faces is some degree of sight compromise, some degree of disfigurement, and that can even be temporary. But often there's a poor clinical outcome. And a lot of times this disease gets worse and worse and then just kind of stays. It doesn't get better. And that's hopefully what we're going to talk about as far as some interventions that can be done, treatments, both surgical, non-surgical, and even over-the-counter, just things that can make the improvement of sight and function a lot better, but also even of appearance. And many patients are actually really kind of feel guilty even talking about appearance with this disease, yet most studies have shown that 80 to 90% of activities and interactions are reduced because of these diseases. People just don't go outside. They don't go to parties. They don't go and enjoy life because of many of the manifestations or the disfigurement of this disease. As I said, this is a very heterogeneous disease. The people who have it kind of know that their disease is a little different than others. We help sponsor a Facebook, group, and everyone is always talking about, well, what happens to you? What do you look like? What's your course like? And honestly, almost every patient has a different pathway. And there's no superhighway where everyone is exactly the same. This is a very heterogeneous disease. And you can see that just from this picture, many of these 9 patients, some of them actually are going blind, and I've had to do surgical, emergency surgery. Some, you could say, well, do they really even have this process? You might not even notice it unless you saw what they look like before or saw some old photographs. So just because one person experiences this disease with a lot of inflammation doesn't mean that someone else will. And so because the disease is so heterogeneous, that means the treatment also has to be tailored to what the patient really is experiencing. And sometimes that's just supportive therapy, sometimes that's medical therapy, sometimes that's surgery, either a small amount of surgery or a large amount of surgery. But these are all tailored treatments rather than a one-size-fits-all. Now, in the past, and certainly even, I think this is true to a certain extent, probably for about 70% of people, they go through what's called an active phase. So patients who do their reading before they come and see me will say, well, do you think I'm in the active phase? But the problem is that the active phase is really hard to define. And the active phase, all that means is that there's disease that's progressing, changing, and that could be inflammation, that could be bulging, that could be double vision, and eventually it stops changing. You'll still have some variations during the day. Like you can wake up and you'll be a little more puffy than you are in the end of the day, but by and large, it's about the same over many, many months. And that's called the stable phase. in the active phase, we often think, okay, well, things are changing. Your immune system is actively attacking this tissue around your eyes. Well, what can we do to help you feel better and to slow it down? And often that becomes the area in which we're thinking medical therapy. We're thinking, how can we help you see better? How can we, do, lubricating drops if you're not closing your eyes? How can we make that better at night? How can we make that active phase more tolerable and potentially use some medications? And we'll talk about the medications. There's a variety out now. It's a whole new world as far as medications that are available for this disease. And then once things become inactive, there's even some medical options, but also then there are even a few surgical options, which have dynamically changed in the last 5 years to the point where, it's a couple-hour surgery and is an outpatient procedure. So there are, a lot of innovations all along this curve of between active and stable that we'll kind of talk about today. This is just, and we're going to see some examples of medical therapy, but I wanted to show some examples of even surgical therapy before and afters. Because medical therapy, and look, I've worked toward a medical therapy all my career, and it kind of overshadows sometimes what can be done. But the real art of medical and surgical therapies often is when you combine them. Because medical therapy will certainly reduce inflammation, bulging, and often it gets my patients 75% of where they want to be. But there's also a role in many cases for surgical therapy. And this is just an example of two patients who both had surgical therapy, who had their eyes moved back with a decompression on the left. There's a bit of shadowing, but you can certainly see that there's a substantial difference. And then the bottom picture on the left is her afterwards. And, really kind of returned her back to her normal appearance. The patient on the right, you could say, well, does she really have bad thyroid disease? Well, if you looked at her pre-photo, she really does. And she didn't like the bulginess of the lower lids. She didn't like the bulginess of the upper. And she had a decompression and a little bit of cosmetic surgery, all done at the same time. And all these take a couple hours to do surgically. Now, not everyone is a great surgical candidate. A lot of people are better medical candidates. And again, I'm not pushing one over the other, but what the real art and the real thing is that it has to be customized for every patient of how to blend medical and surgical therapy together, or no therapy. Those are the three options to really create, I think, an ideal outcome. Any questions before I'm going to talk about a couple cases, and then we're going to turn it over to the panel, who I know is anxious to tell you anything. All right. So this is a famous patient who might even be with us today. And a real-world case, because we've gone to the source and we can actually verify much of this information. And so this is not a real-world case number one. This is a real-world case Jeannie, who's here in the orange. So Jeannie is not going to brag, but she's an amazing night shift oncology nurse who, really wants to take care of her patients and had Graves' disease, but she started to notice eye bulging and double vision and tough working. And she works night shift, long hours. And, throughout this whole Graves and thyroid eye disease experience of trying to function, still wanted to take great care of her patients, really was trying to seek treatment. And you can see that for her, there's bulging more on one side than the other. And if you've never had double vision, trying to pull up medications for another patient as a night oncology nurse is not the time you want to get double vision. That's a pretty tough cross to bear. And can certainly see that, she responded amazingly well. And she's going to tell her story with teprotumumab, a medical therapy. And medical therapy was very appropriate here because we were very early in the active phase. There was no surgery that could really fix this, but the teprotumumab, by blocking one of the receptors that's being attacked by the immune system, was able to reverse the disease. So instead of the constant attack on the eye muscles that's moving them and getting them 5-6 times as large as they normally would be, they shrunk and the double vision kind of went away, not kind of went away, did go away, and the eyes kind of came back into their normal position. And Jeannie's going to tell her story. There was no surgery involved here, because surgery would have just caused more inflammation and it wouldn't have helped. And we could have done nothing, but what normally happens in this disease, if you do nothing, it just turns into scar and becomes double vision forever, unless you later do surgery to fix it. So in this case, medical therapy was a really big win, and again, Jeannie will kind of talk through about her situation. Another active case, a case that you're going to, I think, learn quite a bit about, have a superstar here. Again, a case where, we have moderate to active thyroid eye disease, and again, bulging. And again, when that early phase of the disease where we are seeing active disease and active immune system attacking the tissues and the muscles and causing the eye bulging. And I think you're going to tell us a little bit about what happened here, but also, again, after undergoing teprotumumab, a reduction in the bulging, reduction in the redness, and kind of an extinguishing of the disease. It's kind of like you have a house fire, you've put out the fire. There's still some damage, and there's still maybe things that need to be done, but you've now stopped that fire from totally engulfing and being irreparable as we move forward. So, I thanks so much, Monica, for coming in and going to tell your story. So that's just an introduction. That's just an introduction of what's often in the textbook, a little bit about, some of the, brief hint about the medical therapies and, about the surgical therapies. And that's often what we're going to talk about in therapy is do nothing, supportive therapy, medical therapy, or surgical therapy. And hopefully we'll put into perspective the truths and the myths of both surgery and medical therapy, because I think that what often happens is that perspective and some things get blown out of proportion. But we'll try to put things into perspective for individual patients and individual scenarios, knowing that no one treatment is perfect, but often a combination of them or an individualized approach can really, really make a huge difference. So I think that I'm going to turn over to Dr. Gupta. So Dr. Gupta is an oculoplastic and orbital specialist. Practice together and kind of know each other too. She's my wife. So I have to be on my best behavior and not tell you anything wrong. But she's going to talk a little bit about identifying thyroid eye disease.
Thank you, and I just want to welcome everyone for coming and spending part of their beautiful Saturday morning with us. So we really appreciate your time and efforts, and I'm just going to be moderating. It's really our panel here that's going to be doing the heavy lifting in terms of kind of sharing their experiences with you. And we're going to start off by identifying thyroid eye disease, and we have two other physicians on the panel, Dr. Mock and Dr. Echeverry. Dr. Mock, I will let you kind of explain what you do, and Dr. Echeverry as well, just before we start this section. Yeah.
Hello, everyone. I'm Dr. Audrey Mock. I did a fellowship in plastics and oculoplastics and neuro-ophthalmology after I finished my ophthalmology residency. I've been in practice in Long Beach this is going on my 21st year, and I see a lot of comprehensive patients, but I also see a lot of thyroid eye disease patients, and because I see them having double vision, dryness of the eyes, my partners are glaucoma specialists, and thyroid eye disease is a condition that can affect almost every part of the eye, so it's really a comprehensive approach that I take with my patients. So I see a lot of comprehensive patients, but I also see a lot of thyroid eye disease patients, and sometimes they don't even know they have it until we go over the symptoms that they're having. So nice to meet you all.
Hello, my name is Diana Echeverry Frank. I'm an endocrinologist in Long Beach. I've had an office here in Long Beach for 3 years. I've been in practice since 2007 with another office in Linwood, California. I see a lot of thyroid disease that gets referred to the office. And a lot of the patients have hyperthyroidism, and the main cause of hyperthyroidism is Graves' disease. And along with Graves' disease, people have thyroid eye disease. And so I'm usually the first one to really see it, and it's very distressing for patients. And they'll complain to me about their eyes, or I'll just see it and I can see the lid lag retraction, as Dr. Douglas mentioned. During the physical, we'll see that they have thyroid eye disease. Now, we've had some people come in with dramatic thyroid eye disease, as you've seen in the pictures, but a lot of times it's not that dramatic, but it's still very distressing for the patient, and they tell me that they look very different from what they used to look like. So we treat their Graves' disease, and we decide whether their eye disease can be treated with medical therapy. I'll refer to my ophthalmology colleagues, and they'll also advise, and together we take care of their eye disease.
Thank you so much. So just kicking off this section a little bit, and we'll be focusing kind of on the management and identification, starting with Dr. Mock. What are some of the, I know Dr. Douglas covered a lot of the signs and symptoms, but what are the hallmark symptoms that you often encounter for patients with thyroid eye disease, given that there's a spectrum of manifestations and presentations? How often is it that you see patients who may not have had that diagnosis, may have been told you have dry eye, you have something else, but really do then end up having thyroid eye disease, and how do you pick that up?
A lot of it is a good history and just talking to the patient on what actually bothers him. You would be amazed at how many people just convey that, one, of course, that they don't feel like they look like themselves, but a lot of people are just uncomfortable with their eyes. And a lot of people tell me that they're aware of their eyes all the time. And there's just like, sometimes it can be an ache, it can be a gnawing. The spectrum of pain can be wide, but a lot of people are just not comfortable with their eyes. And so a lot of times we default to dry eyes, but when you take a history and you see what else is going on, sometimes you find out that they're having double vision, but maybe it doesn't come on until the end of the day when they're tired. So the dryness, the pain, sometimes it's my colleagues in my office that are telling me I have a patient with glaucoma, I can't get their pressures under control. And then we do a further look and we say, actually this patient has some more subtle changes of thyroid eye disease. And once we can control the thyroid eye disease, we can control their pressures as well. So it's not always the obvious, the staring lids, the bulging, but there's a spectrum. And so a lot of patients are just telling me that they're not comfortable with their eyes, and then we do a deeper dive into what symptoms they're having.
Thank you. Very well said. Dr. Echeverry, I know that you're often a bit on the front lines because patients are coming to you with underlying thyroid conditions. They may or may not have yet developed thyroid eye disease, but how do you diagnose patients with thyroid eye disease? And then at what point do you incorporate other medical providers into that care team?
It depends on, I'll have a patient come in on the first visit, and I just had one this week. And when we were talking to her, we noticed that one of her eyes would deviate up a little bit. And so we asked her about blurring the vision and double vision at that time. So it usually the first visit, especially if they come in with hyperthyroidism, will determine whether it needs to be addressed. Usually when you treat Graves' disease, the eye disease does get better with the treatment of the oral medication. We do not, the other important thing as an endocrinologist is to assess whether they have TED disease, thyroid eye disease, sorry. And because one of the treatments for hyperthyroidism and Graves' disease is radioactive iodine. And if they have eye disease, I do not consider treating them with radioactive iodine. So I'll move over to the oral medications, and then if I can't control them on oral medications, then we'll move towards surgery for their goiter. So with the eye disease, if it's bad enough, that's when I refer to ophthalmology. And I'll use, there's a scoring system called Clinical Assessment Score, and based on that, I may use that to refer out, usually in the first, second, or third visit, depending on the severity of their disease.
Great. And Dr. Mock, when you see a patient that you think this patient kind of has the telltale signs of thyroid eye disease, whether they've been referred to you for that or you pick that up, what are your next steps in terms of workup for those patients?
So a lot of times if they haven't had a thyroid panel, I will check thyroid levels before referring to an endocrinologist. You can have normal thyroid levels and still have thyroid eye disease, however. So I tell patients, we're going to get these levels, but it's not the end of the story. Sometimes I will order a CAT scan as well of the orbits to take a look at the anatomy, and that will typically be my starting point.
Okay. And do you ever incorporate other physicians into your care team beyond endocrinology, just out of curiosity?
I would say the endocrinologist is the biggest partner. Some patients don't have endocrinologists,
Yeah.
so they're especially if they are an HMO. So then a good partnership with their primary care doctor to kind of say, hey, this is what we're worried about. Can you do more of a workup on your end as well
Okay.
and facilitate a referral?
Great. So we kind of covered this. Once you diagnose a patient with thyroid eye disease, kind of the goals are, right? If they don't already have an endocrinologist, you want to get them to an endocrinologist so that their underlying thyroid function can be worked up. But what can patients expect from a quality of life perspective? Because I know so much of this disease, as I mentioned, is often patients, there's a long time to diagnosis because sometimes the eye symptoms are so subtle that you haven't been diagnosed with thyroid eye disease, you've been told you have dry eye or something else. And once you get that diagnosis, in your experience, does that change from a patient's perspective and like quality of life perspective to have a label on what they have and a treatment plan moving forward?
I think just having the diagnosis, it's not that it gives you a relief to have that diagnosis, but at least hey, I have something that I can, there are resources in this spectrum. There are treatments in this for this condition. And so just having a diagnosis is having power over what the next steps are. And I will tell my patients, we're in this together. There's such a range of thyroid eye disease. And so I say, I'm with you to keep you comfortable throughout this process. And we will explore the different options, and I will give you all the range of options, and you tell me what is important to you, and we will figure out a regimen that works for you.
Okay, thank you. Did you? Yeah, please do.
I forgot to mention that one of the things we do check for in patients with, to determine whether they have Graves' disease, if they're hyperthyroid, is we check for antibodies. There's thyroid-stimulating immunoglobulins and thyrotropin receptor antibodies, and those usually are very high in Graves' disease, and they're also associated with the severity of their eye disease. So I will follow that. And if somebody is euthyroid, meaning that their thyroid is normal function, but they look like they have eye disease, I will check those antibodies. And I have found some patients to be normal thyroid function, but have elevated thyroid antibodies. So that's one way of determining is this thyroid eye disease.
Thank you for clarifying that, because I think that's a question asked by a lot of people. Moving on to more of treatment, because we've identified it, and now we're moving to the treatment options, which have changed over the last 5-6 years quite dramatically. Historically, how have you each treated patients with thyroid eye disease?
When I was first going through fellowship, most people sometimes people had radiation and sometimes they had decompressions, and the decompressions in the old days could be quite disfiguring, and patients never looked even closely to what they looked like when they started off. So even the surgical treatments have come such a long way in restoring just function and appearance to patients, even though you would maybe prevent them from losing vision. The restoration of the way you look is such an important part of this condition, and having more options now that are not disfiguring are so important, I believe. So there's Tepezza to me, which is one of the biologics, has been a game changer in my opinion, in my patients just feeling more like themselves. And I'm happy to offer that option to my patients. And then there's, even offering them supplements like selenium for people with mild disease. Maybe it will help them. And just a lot of lifestyle modifications in terms of, things you can change in your environment to help your eyes be more comfortable. So I think some of the medications have come a long way. The surgical treatments have come a long way. And definitely the biologics have, to me, added a revolutionary aspect to this disease.
Great. Dr. Echeverry, just love your perspective.
Well, we treat the Graves' disease, and usually the eye disease will get a little better. But steroids, we used to use a lot of steroids, and with high dose steroids comes other issues. So I would be very hesitant to use steroids in a lot of patients, especially when they're diabetics, because of the really high blood sugars that you can get from high-dose steroids. But we would deal with the diabetes, and then you also have to worry about their bones and all the other effects from high-dose steroids. So that was the main treatment that we would do that was medical. But in severe disease, of course, we would defer to ophthalmology urgently and send them there. But sometimes I would treat with steroids while they're getting into ophthalmology. And so that was basically the only treatment we had. And selenium now, we have some studies showing that it does improve thyroid eye disease. So I've been recommending selenium for mild disease, usually.
And just moving on from that, how have recent advancements, and what recent advancements, I know you spoke to it a little bit with advances in surgery, how have they changed how you treat patients, and how effective are these treatment options?
In terms of the medical treatment options, I don't think we've started talking about Tepezza yet, but I've mentioned it, and it's an infusion medication. So it's, to me, been a wonderful option to give to my patients in terms of, I will give them surgical options, I'll give them medical options, but it's really nice that they have the ability to decide what's best for them and their case. So Tepezza, I feel like, has been wonderful for many of my patients in improving definitely the bulging, or what we call the proptosis, but more, in addition to that, patients tell me that they're so happy that their eyes are more comfortable. The dryness is better, that they're not having that aching behind their eyes. And so for me, hearing from my patients, that's been a game changer with this medication. Prednisone, yes, I used to give a lot of prednisone as well, but for limited times, and you would feel better on the prednisone, but then you stop it and then you start feeling worse again. So the Tepezza has given a lot of my patients long-term comfort with the eyes, and it's also helped a lot of them with their double vision. So maybe some of them still need prism, which we can put it in glasses to help with the double vision, but we're putting in less prism, and we stabilize them before they need surgery. So it's been a wonderful addition to the armamentarium.
Thank you. Sure, of course.
So yes, we've treated quite a few patients with Tepezza, which is easier to say than the actual name. And it's been very dramatic improvement in patients. They feel good after. They'll start seeing results even after the first few infusions. And we've been able to delay or surgery, or actually avoid surgery altogether with this treatment. And it's much more effective than steroids were ever for the use of relieving all their symptoms from moderate to severe thyroid eye disease.
Sorry, let me add, there's definitely still a role for surgery. In some, Tepezza does take time to work, so if patients are actively losing vision, they definitely need a decompression so that we don't, the number one thing in this treatment is to preserve vision. And so if we can't preserve it, if we're in the constraints of time and someone's actively losing vision, I will refer them for a decompression. And sometimes even with the Tepezza, they still need a decompression later on because they still want some additional reduction in the amount of bulging. And patients still may need sometimes surgery for the muscles so that they don't have double vision, and eyelid surgery so that their eyes don't look like they're staring as much. So surgery is definitely a big part of my treatment plan as well, but we have so many options more to give those patients, and we can have those conversations with each person so that we tailor the treatment to each person.
Thank you. And I think to your point, surgery still has a very big role, but as our medical therapies have advanced, the invasiveness in many ways of the surgeries, has reduced, because even if patients do need a decompression, it's a lot smaller decompression than what they needed to bring their eyes all the way back before. So they can be tailored, and sometimes they're just easier on patients because they're not quite as invasive. So in terms of newer treatment options, you touched on some of the benefits of it. Maybe we could touch on some of the potential risks of some of these newer treatment options as well.
So in terms of the Tepezza and the side effect profile, I always tell people, definitely if you have inflammatory bowel disease, you're not a candidate. If someone's sugars are not well controlled, I have the discussion with the endocrinologist, like, can we get these under control? And definitely I talk to everyone about the risk of hearing either ringing in their ears or hearing loss. So if patients have pre-existing ringing in their ears, I will work together with their ear, nose, throat person or refer them to an ear, nose, throat doctor so that they can get baseline audiograms, and we have the discussion, are you a candidate for this treatment? So we definitely want their input on this, and we want to follow the patients along with their ENT surgeons to make sure that they stay safe throughout the treatment. The other side effect profiles for most of my patients, all of those have been temporary, but I'll tell them, possible muscle cramping, possible changes in your hair and nails. Definitely you want to hydrate during those treatments. And then some people have gotten temporary increase in their blood pressure, which we manage with their primary care doctors as well.
Wonderful. Dr. Echeverry, if you'd like to
Yeah, I
add.
think Dr. Mock hit it all. But basically, hyperglycemia and worsening of diabetes is a bit of a concern, but very manageable. Nothing like what steroids used to do to, what steroids do to blood sugars. And then the hearing, if they do have any history of hearing issues, ringing in the ears, I will refer to ENT to get evaluated prior to starting treatment. Otherwise, it's very, I haven't had too many patients complaining of ear issues. And the hyperglycemia has been very mild and very manageable. The cramping, we get some patients with the cramping, but they usually are able to tolerate it, and it does go away after the infusion.
Dr. Echeverry, I'd love to get your perspective, because prior to having the newest therapy that was approved in 2020, teprotumumab or Tepezza, as Dr. Mock mentioned, often are only really first-line medical treatment for patients with really active, severe thyroid eye disease that was not affecting vision was higher dose steroids. So comparing like a high dose steroid course to Tepezza in terms of side effect profile or how patients experience it, in your experience of probably managing both patients on steroids versus Tepezza, like which one would you say patients have an easier time with, or managing the side effect profile is easier?
The managing the side effect profile from Tepezza is much easier, at least on my part, with blood sugars.
Okay.
Steroids can raise blood sugars into the 500s, 600s at times. And the important thing here is that if you treat for 1 or 2 weeks with high-dose steroids, They'll feel good during the treatment and then maybe for a few weeks after, but tends to come back
Right.
and need retreatment.
Exactly.
That's when you worry about the effects of steroids.
And I think it's important to highlight that steroids are anti-inflammatory, so while they reduce the inflammation, they don't actually reverse the disease. So they make patients feel better, and if there's a lot of swelling and redness, that does help. But ultimately, it doesn't move the needle in how they progress through their disease. Dr. Mock, what else, are you aware of anything else that is up and coming in the space if a patient isn't an appropriate candidate for the therapies currently available?
I know they have some clinical trials ongoing for new medications that have some new biologic infusions. I think they might even be working on some that might be a subcutaneous administration. And they work in a little different mechanism of action. They work on different molecules. I don't think any of those have been approved yet, but we know that at least there's funds being diverted to, study thyroid eye disease, which is much better than what we used to have 20 years ago, which was nothing. So it's an exciting field, and I'm happy that we have more options along the way to offer our patients.
Yes, hopefully more coming soon, definitely. Well, thank you both for your perspectives. I really appreciate it. So we're going to just transition to speaking with Karen Mullen, who is the co-founder of Thrive. She heads our finance and care coordination teams. A lot of experience Karen has with dealing with biologics in thyroid eye disease, but also to treat other conditions. But Karen, would love your perspective on all things related to getting Tepezza for patients. But to start, what are high-cost biologics, and do most insurances cover them? If you could just give us a little background.
Sure. Thank you for having me. High-cost biologics are complex biologics given in IV or injectable formulations. And they are typically just that, high cost. So it can be a little challenging to navigate our way through insurances because they do fall under a different level of scrutiny at the payer level and utilization management level. So something to be aware of. But yes, they definitely are covered by insurance policies. They are actually easy to get authorized. And we'll talk a little bit more about that as we go.
Okay. In terms of authorization, how long does it typically take to get an authorization for Tepezza once a patient has been evaluated by a physician and that's been deemed an appropriate, method of treatment?
Yeah, so for first course of treatment, it's pretty easy to get authorized, even though it is a high-cost biologic. Usually it takes anywhere from 3 to 5 days to get an authorization. We set it up very well, though, before ever submitting to insurance companies, have all of our ducks in a row. But we've gotten them authorized in as little of time as 2 hours before. Now, that's with the use of AI, I'm sure. But, but I will say, though, that as the drug has been on the market for a while now, Tepezza, it's easier to authorize. Insurance companies are familiar with it. So first course of treatment, it usually runs through pretty quick. Where we're challenged is with second, third, fourth course of treatment. We've gotten as many as 7 courses of treatment to date authorized, and that can be a little challenging as we go, but as long as we can show medical necessity through way of their wonderful notes around it, and it usually is still pretty easy to get authorized. Could take up to a month, though, sometimes, but we'll take it all the way to the different entities that would give us authorization, second level appeal, insurance commissioner's department, whatever we can to get patients on therapy.
Yeah, I think the most important thing is having a team behind you that's really advocating for you, because as a patient, you can't make that happen on your own. And one important thing to consider is Tepezza, which we're talking about right now, which is an infusion that some of you may be familiar with. It's administered every 3 weeks for 8 treatments. So you are kind of committed usually for about 6 months of treatment. And practically speaking, life events happen, people change jobs or move. What happens if your insurance changes mid-treatment?
Well, provided the policy that you've chosen for the next for the remaining course of treatment, accepts and authorizes Tepezza, which I can usually overcome that if they don't. It's actually better if they start mid-course with a new policy, because I'm showing all the information on the last policy and the prior authorization that we obtained with the last policy. So now insurances are in a position where they have to justify stopping the patient mid-course. So those are usually pretty easy to get authorized. But it can be challenging, though, if the policy doesn't allow for that particular treatment, but not impossible.
Okay. And in the event that a patient's insurance denies coverage for Tepezza, what are a patient's options?
Well, there's lots of programs out there to help our patients. So we have some patients that just don't have any insurance at all, or they have maybe catastrophic coverage that only allows for hospital-type emergency room kind of coverage. In those cases, there are foundation programs available. Amgen offers some wonderful gap coverage programs. So those are some options that we have. But looking at anything possible out there, to get this covered, usually are a lot of options to us, though.
Wonderful. We're talking about high-cost biologics, and Tepezza is a high-cost drug. What programs are in place to cover out-of-pocket costs? Because I know that's a big concern for patients or anyone who's about to start this therapy, and other related expenses.
So Amgen covers most of the patients out of pocket, which is very, very helpful. They have copay assistance programs. But also for the Medicare Advantage patients who do have an out-of-pocket that is not covered by Amgen copay assistance programs, there's foundation programs available that do work very well with these Medicare Advantage plans. So important to know. But there's lots of help in the way of Amgen copay assist or foundation programs to help the patients out of pockets.
And what would patients' out-of-pocket costs be for a Medicare Advantage plan or Plan C?
So those can range from a zero out-of-pocket. LA Unified School District, for example, doesn't assess any out-of-pocket to their retirees, but it could go all the way up to about $9,000 in out-of-pocket costs, which is important to know and understand. But usually, again, these foundation programs are able to cover those out-of-pocket costs for the patient. But it's important to know that a Medicare Advantage plan does assess an out-of-pocket for these medications, which again aren't covered by copay assistance programs.
Okay, so we thank you so much for our speakers thus far. We're open to any questions, which you're welcome to ask now, but we are going to take a little break. So feel free to come find one of us, 15 or 10 minutes, and then we'll resume. Thank you. So thank you. We're just going to conclude our morning with some insight from our really lovely patients who are so kind to spend their morning with us, sharing parts of their journeys. So this, as Dr. Douglas mentioned, we have Jeannie Twisk and Monica Penaranda here. Sorry, I just met Monica today, so if I mispronounced your last name, I apologize. But thank you both so much for being here and sharing some insights from your journey with thyroid eye disease. But Jeannie, we'll start off with you. Can you describe some of the early signs of thyroid eye disease and how it eventually escalated and was diagnosed for you in terms of thyroid eye disease?
Sure. So a while back, so I'd say about 6 years ago, I started having some really gritty, itchy, dry eyes. I had had a sinus infection, so I thought it was something from the sinus infection, kind of a lingering sign from that, but it just lingered and lingered and lingered. And soon my eyes became really bulgy, and I started having double vision. And that was a very slow progression at first. I'd say the grittiness and the redness were probably the keystone problems at the beginning, and then the proptosis of the bulgy eyes and the periorbital edema, so the swelling around the eyes, became really evident a little bit later. So those were the beginning signs and symptoms of that. It just escalated, and it became, within 2 months, I would say, I had one eye much larger than the other, one eye, just sort of that stare that we talked about earlier, and the tearing and the redness that just never went away, along with pain behind the eye, which never really went away. So that was it's just a hard time.
Thank you for sharing that. And Monica, could you walk us through the kind of the beginning of your experience and what were some of the first changes you noticed and how did they kind of progress and evolve?
Yes, so I would say the very first symptom I had was my eyes just went crossed. I did not know what double vision was at the time. And it didn't happen often. It was every so often I just felt like, what's going on? I'm seeing funny, and it was very scary. And then my eyes became very bloodshot red, and I found myself carrying around the Lumify eye drops. I know we're not supposed to use them. I didn't know then. And just so that I would look normal. And then the blistering of the whites of my eyes I had in the corners, and I kind of still have it now, but pockets of like, I wanted to just like pop it, but it, obviously you can't. That started, and then my eyes started bulging. Then the grittiness and the pain. So it all kind of came together. But the beginning, it was just a little bit of crossed eyes, which now I know is double vision.
Okay. Yeah, and I think probably a lot of people can relate to those early symptoms and maybe not even knowing exactly what they were. That fluid that you mentioned on the surface of your eye, kind of like a little like fluid blister almost, is called chemosis, but that's a very common finding in the more inflammatory thyroid eye disease. Jeannie, what led you to seek care, and what was the process like before you got an actual diagnosis of thyroid eye disease?
Oh, wow, that was hard because nobody really knew what I had. So I went to my primary care physician, and he thought, wow, there's something wrong with your brain because the right side of your face isn't working and your eye is bulging, and so let's send you to a neurologist. And the neurologist looked at me and said, wow, that's a nice party trick because one eye's looking at me and the other eye is looking over here, and what are we going to do about that? And so we'll do an MRI. And they did an MRI, and they said, oh, well, I think you need to see a neuro-ophthalmologist. So by the time I got to the neuro-ophthalmologist, I had already seen several ophthalmologists that didn't know what was going on. But by that time, I had already looked online and thought I had thyroid eye disease because I had just been diagnosed with Graves' disease. So that sort of was in the literature that might follow, or that it could predispose, or it could come. So the neuro-ophthalmologist that I saw at the time said, yes, I do believe you have thyroid eye disease. It was about a 6-doctor journey to get that diagnosis. It was probably a 6-month journey to get that diagnosis because, as you know, it's not easy to go and just see a doctor. You have to wait your turn, and I waited my turn as patiently as I could, but by the time I got the diagnosis, I knew that, okay, I have thyroid eye disease, and what are we going to do about it now?
Yeah.
Yeah.
That's certainly a long road, and I'm sure you have a lot of patience.
It was a very long road. It
Yeah.
was real long. And I think that is a normal thing for people, unfortunately. I think that a lot of people don't know exactly what to do with these patients that come in with very dry eyes and bulging eyes and maybe some periorbital edema.
Now, Monica, what prompted you to seek care, and how did that path unfold for you to get to the diagnosis?
So I'm smiling because my path was really weird. It was unique. So I have other conditions as well on top of thyroid eye disease, and it puts me in a place where in the medical community where I learn about paid market research studies. And I have a friend, she's actually here now, she has she has Graves' disease as well, and she told me about this paid market research study that revolved around thyroid disease. So I applied and was accepted, and it was a virtual Zoom meeting, and they didn't use the word Tepezza, but they showed me images. They did use TED, and they showed me images of eyes. I'm telling you, they were the most beautiful pictures. It was like artwork. The eyes, it was an eye with like a rough sea and a sailboat for watery eyes. Or there was another eye that had like, it looked like the cracked desert of the floor of like the desert, the ground. And for dry eyes. And every picture that they showed, I said, wait a minute, that's me. I have that too. The redness, the itchiness, the swelling, the bulging, the pain, like it's all me. And I had no idea of anything about TED before. So I just knew I had all these symptoms, and the double vision wasn't as bad then. So I got off the call, and I called a fellow friend who was a retired ophthalmologist. And he told me who to see, go to an oculoplasty specialist. I called UCLA, got into a specialist, and they referred me to Dr. Douglas to Thrive. So I kind of diagnosed myself in a weird way. Yeah, I'm like, that's all me. So, yeah.
While letting them know that their marketing or their educational tools were spot on, right?
Yes, exactly.
Now, moving back to Jeannie, I know Dr. Douglas mentioned your work as a night shift oncology nurse. As you were going through this and dealing with these symptoms of double vision and other things, like what kind of challenges did that present in terms of your work and just like your day-to-day life and activities of daily living?
Sure. So it was really difficult to do work. I had an area of single vision, and I'm lucky in that I could stand and my patients were in their beds. So my area of single vision was down here, so at least they were not double. So I could at least see my patients. It was really hard to do charting on the computer. The brightness of the lights, any kind of fluorescent lighting was really difficult. And hospitals are known for such great lighting. So again, I was sort of lucky that I had night shift because we could dim those lights, and I could sit in a small dim room and not have all the extra lighting going on to distract from charting. Just having to pull up medications, having to look at vials that are so tiny, and then having double vision, that was always very difficult. So what did I do? I managed by doing things a little slower than I was, and I was really, really quick. So my colleagues were like, do you need help? Do you need help? And it was kind of a constant thing, and I'm like, I don't need help. I just need a little extra time, and so yeah, it's really hard. I, at one point, had to stop working because I didn't feel like it was a safe thing to do, to go on with working and in the patient population that I had. And that is really hard. I will say that one thing for thyroid eye patients, when they stop working, it means you're really sick, right? Like that's the one thing that maybe kept me personally feeling like I'm okay because I'm still working. I'm still helping my patients. But at a certain point, I couldn't do that anymore. And then I felt really sick. And then I really had to listen to my body. And I think that's the other thing you have to do is listen to your body when you have this disease. So yeah, you manage by doing things a little slower. You manage by dimming lights. You manage by wearing sunglasses, lots of sunglasses, the bigger the better. You manage by not going outside, right? So you become a little bit more reclusive. You don't have the same energy you have because you have pain and you have, I got a lot of nausea from just having the double vision and feeling like I was on a boat. So I didn't say yes to a lot of things that I normally would say yes to, parties, hosting things, going out with friends. You become really reclusive, and that is a difficult symptom of this disease for the patient because you just say no to a lot of things that you otherwise would say yes to.
Which is why we're so thankful that you said yes to being on the
So
panel
happy to be
today.
here.
Yes. Moving to Monica, how did it affect your day-to-day life? And now that you've recently completed treatment, like what kind of changes or improvements have you noticed in your ability to just do the simple day-to-day things?
So the way that TED affected me was, I would say, in two big ways. One, of course, was the double vision, not being able to drive. Living with other chronic illnesses, I felt like being able to drive kept me feeling like I was still independent. And when TED hit, I lost that sense of independence. Where just walking down the hall of my home, I would shake. So I was very unsteady. and feeling like you can't control your body is something that you just, it's very hard to live with. And then the other thing, and it may sound vain, but so like I've said, the other illnesses, I have had central lines coming out of my chest. I've had pumps, external, internal. Currently, I have an internal pump that looks like the size of a can of tuna. I call myself Iron Woman, and that keeps me alive. And it's big things, keeping my heart and lungs going. None of that ever made me feel self-conscious. I could show the can of tuna, my surgery scars for my open heart surgery. It's like I wear them like a badge of honor, and all of those things, it's just me. That's who I am for the last 28 years of my life. TED changed my face to the point where I couldn't look at myself in the mirror. I didn't want pictures taken of me. I didn't want to go anywhere either. I didn't want people looking at me. And the diseases that I've had, they're considered invisible diseases. People can't tell that you have what I have inside of me. TED is just right there. And so family, friends, are you okay? You don't look so great. Thanks. It really changed who I was in a big way. And it was hard. So after I will say after my first half infusion, I was already kind of starting to see my face looking like myself again. And once I completed all 8 infusions, it was like I found my new normal again. I'm driving. I get in my car and I go. And I'm able to continue to do the things that matter most to me. And that's so important.
We're really happy to know that you've had such a marked shift in life and how you experience this disease following treatment. And one of the things that I want to point out that you kind of alluded to is we talked a lot today about how thyroid disease affects the eyes because we are oculoplastic surgeons. We deal with the eyes, but we know that it doesn't just change your eyes, it changes the shape of your face because it expands fat in other parts of your face, your cheeks, the fat around your brow. And so it's not just a change in your eyes, it's a whole change in the shape of your face. And one of the things that's wonderful about Tepezza that is known from studies that Dr. Douglas and colleagues have done is that Tepezza not only shrinks the tissues behind your eye to bring your eyes back, but also changes and reduces the fat size that has expanded in your face, allows your face to get back to a more normal, whatever it was pre-disease for you, which I think is really important too, because it's not just, obviously the functional things are important, but when it changes the whole way you look, that's important too, and getting back to a sense of self is really important.
I want to speak to that. I experienced that completely. I had a lot of thickening of the brow. My nose, I have a really small nose, and it was so broad at one point, and the buccal area of my cheeks just really got very squared. It looked sort of Neanderthal, for lack of a better word. And I will say that after that first infusion, the inflammation just damped it. It just took it right down, and what a relief.
Yeah.
So, yeah, I
Good.
will attest to that.
Jeannie, how did you finally find the right doctor, and how did things and what changed for you after that?
I found Dr. Douglas because I looked on the interwebs. I asked my neuro-ophthalmologist about this amazing doctor that was studying thyroid eye disease. And at that point, there weren't very many options. So I cannot fault her for saying, you're not the worst case I've seen, and I don't know that I would send you to Ray Douglas yet. And I thought, I don't aspire to be the worst case you've ever seen, and I feel real bad right now. So I sat on that for a little while thinking, I'm not the worst case. Okay, that's good. And then it wasn't getting better. It was actually getting worse. And then I just made a call. And I am so grateful that I made that call. So, and I got in and I got to see Dr. Douglas, and he said, yes, in fact, you do have pretty bad thyroid eye disease. And he started treating the thyroid eye disease, and I have never looked back.
Okay.
That's it.
Monica, we were talking briefly on the break, and I'd love for you to share that perspective because you were telling me about the support that you had while you were going through treatment. So just wanted you to touch on the support that you got from your medical team, what other resources you found or support groups that were helpful for you that you might suggest to others.
Yes, so when my oculoplasty specialist referred me to Thrive, and they put my paperwork in, I got a call from this awesome person, human being, from Amgen, and he literally guided me through the whole process that I was about to begin, even from the big questions for me were, what are the side effects? And, he couldn't talk to me about those things, but referring me to the website that had side effects and safety information, and the website was really thorough. Yes, and with just questions like parking. It sounds so trivial, but where I went for infusions was in Beverly Hills, and he told me, here's the parking structures on this street, and this one's less expensive, and I didn't have to use parking structures because I have my handicap placard, so I parked on the streets, but that was really nice. And then he also connected me to a fellow patient. I believe she was in a different state, Connecticut, I want to say. And we had a good conversation, and she calmed a lot of my anxieties and my nerves. So before I even walked into Thrive, I had this wealth of information, all these links, who to call for a driver if I can't drive myself because double vision takes your driving away from you. And they had that for you. So there was a lot of support from the very beginning. And then once I got to Thrive, I developed I loved the team so much. They were awesome, and I felt like my health, I had a lot of fears about what is this infusion going to do to me, because I'm already on so many medications, and I already have so many side effects. So that was something that I was really nervous about, and the team there guided me. I felt like they held my hand through the whole thing, answered every question. If I wanted to talk to the doctor, he would come and speak with me. And what was his name?
Dr. Wong?
Dr. Wong.
Yeah.
I'm like, I couldn't think of it. And by the end of my 8th infusion, I was actually sad to go because I wasn't going to see these people anymore because I became part of my life. So it really, I felt supported. I felt like my hand was held. I felt my nerves were calmed. The whole process was seamless, I want to say.
Yeah. And I think to your point, whoever is part of your care team, I think you have to feel really comfortable because you're kind of committed to this long journey with them, and you do end up spending a lot of time in their care.
Oh, and one more thing. And when you're having the infusions, they're taking really good care of you. They're checking your blood pressure every so few minutes. They made sure that they were checking my ears, so that I did hearing tests periodically when I would be there for my infusions. So I felt safe too.
Yeah. Now, question to both of you, which I think is often on the forefront of patients' minds because we talked about cost. What was your experience navigating the process of, in terms of getting TEPEZZA approved and any co-payments or anything like that?
I have nothing to say because you were so awesome. Thrive was amazing. They literally did everything. I didn't have to talk to my insurance, and I'm a professional patient. Yeah, I'm a professional patient. So not having to pick up the phone and call and hassle anything, and it was amazing. You just kept me in the loop and letting me know the steps and what was happening, and it was like a flawless process. So, and I just couldn't wait to get the infusions going because I wanted to be better. So, Thank you.
I'm going to add to that Karen is just a beautiful part of this machine and really keeps things going. And thank you for getting all the insurance taken care of, because it is really daunting to go in and have to talk to your insurance company. They like to say no, but they don't say no to you, so that's good. She does something, I don't know, it's great. So it really was seamless, like you said, Monica. It's nice to know that somebody is there that is really advocating for the patients and able to get things covered. So thank you.
And then just some final remarks from each of you on what you would tell someone who's recently diagnosed and maybe feeling a bit overwhelmed.
Recently diagnosed, I think listen to your body, get the information that you deserve. So go and seek the information. Make sure you are comfortable with your care providers, and Thrive has been amazing. This is a great group. I have certainly felt safe with every infusion, every step of the way. So I would say just know your care providers and trust your care providers and get informed.
And just to add, there's one thing that I've noticed. When I first got diagnosed, I go to Facebook to find out what other people are going through. And I see a lot of comments, posts from people that may have tried Tepezza and it didn't work for them, or they may have tried this, it didn't work for them. I would say, remember that our bodies are all different. No one is going to have the same response. Unless you try something, you won't know how well it works for you. I've been in quite a few clinical studies, and it's scary to start a drug that you don't know what's going to happen to your body, but you never know how it can help you. I know that I'm still alive because I've said yes to trying new drugs and trying things for myself. So I would say don't be afraid to try something, because you never know how well it's going to help you, and just keep taking steps towards your healing. So I encourage you to just say yes. Say yes to trying something.
I second that. I second that.
Thank you both so much. We really, really appreciate your insight, perspective. I think so many people can probably relate to the journeys that you've been on. I'm going to hand it over to Dr. Douglas for closing remarks. But before I do that, each of you should have like a little survey on the table in front of you. And if you could just spend a few minutes filling that out and you can just leave it on the table, we'd really appreciate it. It would help us out a lot. So.
While we get some questions formulated, I just want to thank everyone for spending their Saturdays. I mean, we've been doing these types of seminars probably for 20 years, on and off, and various levels, and it really is a highlight for me because I get to listen to my colleagues, patients, and people who really, really care about every part of this journey and about making it better. And so if you have suggestions of things that we can do educationally, et cetera, that could make it better, reach out to more people, we'd love to hear those, because honestly, it's a fun part of doing these every couple months to try to reach to patients who are really frustrated with the process, with the disease. And it's fun coming together and hearing success stories, but also learning from my standpoint. And I really want to thank everyone for spending their Saturday this morning, both in the panel but also in the patients today. Yeah. Thank you.
That's a great question. And actually, no. With a prior authorization in place, that's the gold standard. As long as we have a prior authorization in place, then insurance is on the hook to pay all 8 visits during that one course of treatment. It's only when a patient has a lapse in coverage that it can be challenging for us, where maybe they haven't paid their premium or they lost their job. Then that's when insurance won't pay for those services. So you're good there. And, we just want to say it's very important for our patients to know that we go to, the extra mile to make sure we have a prior auth, a pre-certification, or a predetermination. And so that's the key here of success, is making sure that you have one of those 3 things in place in order to go forward with therapy, because it's really your insurance policy that insurance is going to pay.
I definitely did, to the point where I couldn't put makeup on anymore, and I'm a former makeup artist, so that was really, really hard for me. So being able to put eyelashes back on was a big plus for me. But also eye creams, I couldn't even put eye creams on, and like anything that would touch my eyes, and the watering was so bad that I always had a tissue. In fact, I started watering again this week, but I've had the fans on because of the being hot again. But the watering was so bad, I felt like I was constantly crying. So yeah, that affected me. The same. Hearing you is like I'm just hearing myself speak.
I had constant tissues, cloths, whatever, and yes, creams were off limits. No eye makeup, and wind, terrible. Light, terrible. It was everything. You know when you just know your eyes are there, because people that don't have this disease don't realize their eyes are functioning. You just go around your day and you're seeing everything, and you don't realize that your eyes are there. But you know your eyes are there when you have thyroid eye disease, because every aspect of your eye you feel, all the way to the back, to the pain that can come to the back, from the back of your eye. I actually found more relief with warm compresses than with cold compresses, but that is, again, so personal. So I used warm compresses, not hot, just warm.
And just one thing about the cold compresses, that's actually very true. I advise patients always wrap in a washcloth, ice or something, because your skin is really sensitive and can burn your skin even from the cold. And a lot of my patients alternate between warm and cold. Cold shrinks the swelling, warm kind of makes the eyes feel a little more soothing, but it's tough no matter what. Yeah, so it's a great question. So, Tepezza, again, is an infusion of an antibody. And the antibody lasts for about 3 months in your system. And you do 8 infusions once every 3 weeks to kind of replenish the antibody in there. And for 80% of patients, there's an improvement, and it shrinks the bulging of the eye. It actually improves the tearing. It actually returns the lacrimal gland that produces tears kind of back to normal and improves things. And for 80% of the patients, that's all you'll probably ever need to sustain those results moving forward. For about 20% of patients, they can have what's called a reactivation. And reactivation is tough because we don't know exactly why the disease reactivates or comes back, but it does. And even without Tepezza, it has. And there's a reactivation rate of this disease in general. And for about 20% of those patients, they might need a little bit more Tepezza, or what we would call like a second course, something like that. And again, about 80% of those patients do really well long term and don't need anything else either. So in general, it is not intended to be a lifelong therapy, intended to be more short course. We've had actually a much better results as far as durability and achieving it, because a lot of times what we do is we really stress other life factors for you that actually aggravate this disease, including diet, including kind of understanding how gluten or high sugar content or even some other things, and even starting an anti-inflammatory diet can really help with that. And also making sure your vitamin D levels and selenium levels are also maximized, and even trying to reduce some of the stressors of life. And so those are a little harder to quantitate, but it really does seem to add and reduce the need for any additional treatments, and hopefully make you healthier as you move along. Just as Dr. Mock was saying, there hasn't been any new treatments in the last 50 years until 2020. And that was the first, and that became Tepezza, that blocks a molecule called the IGF-1 receptor. There's another medication that's coming out within about the next 6 months that will also be almost identical when it will block the IGF-1 receptor with a monoclonal antibody. And that's going to be given IV. It'll be slightly different infusion schedule, but pretty much the same exact molecule. There are several other clinical trials, one of which has been concluded with mixed results, looking at a molecule that kind of impairs the immune system. It's called IL-6. There's a drug out that's very similar. It's called Actemra. It's been, or tocilizumab, but Actemra is the trade name. So it's been used a bit, and sometimes if people don't respond to Tepezza or have inflammation, we'll try that drug. It doesn't seem to be nearly as effective, and then one trial had a positive result and one trial had a negative result, so it's unclear whether they actually come to the market or not. The other molecules that were introduced had a very, very different mechanism. They've all been actually withdrawn because they didn't work. So right now, for about the next 2 to 3 years, there really won't be any other molecules besides this one in the next 6 months, which is very similar to Tepezza. In about 2 years, there may be an oral molecule that doesn't have as many side effects, but that's probably at least 2 years away. And then there's another class of molecules that's probably another 3 or 4 years away.
To address the first part, absolutely Tepezza is great for patients that have double vision. The original endpoints of the trial, it was for proptosis or bulging of the eyes, but there are a lot of my patients that have had an improvement of double vision. Not everyone has the double vision go away, but most of my patients have definitely had an improvement. So that may decrease the amount of prism that they need to use, or if they eventually need surgery, as some patients definitely do, the amount of the surgical correction is less than they would have needed if they hadn't. I mean, I've had a patient that was a pilot that was able to fly again after using Tepezza, which was a huge win, because had she had other treatments, she wouldn't have been approved. So that's one of the big victory stories in my practice. But to speak to the second part, double vision can go away with on its own. Everyone has a different course, and not everyone has double vision all the time. So it tends to fluctuate. There are other conditions that may need to be considered. That's a whole nother talk, but myasthenia can sometimes go hand in hand with people with thyroid eye disease as well. So that can also cause double vision. So we may need to evaluate that. But I do have patients, as their disease improves, their double vision goes away. My role is to keep people comfortable along the journey with maybe needing prisms, prism and glasses, appropriate referrals when the time is right to a pediatric ophthalmologist that does muscle surgery.
So when Tepezza was first brought out, I sat on the FDA panel, and we had 4 cases of hearing decline or hearing changes. No one ever thought that Tepezza and hearing would have any issues to get, at all. And those patients seemed to do better, and there really wasn't much thought of it. Even when the drug came out, the rate was 10% of hearing changes, and they were just all lumped together. It wasn't necessarily hearing loss, etc. Then afterwards, it turned out that a significant number of people, probably around 10%, seemed to be having these longer-term changes, and especially older patients needed hearing aids or were noticing this. And that became a little bit more alarming in that people were noticing long-term changes. Since then, we've done prospective studies actually looking at hearing loss. And there's a couple things that are really, really important about hearing loss, is that it's mild. The average decline is less than 5 decibels, and breathing is about 5 to 10 decibels. So it's a small decline if there is a change, but that doesn't mean that it's insignificant. The other thing is that if you have a normal audiogram, you almost are assured probably not to have any problems with Tepezza and hearing changes. You have less than a 1% chance of having any kind of hearing problem as long as you have a normal audiogram starting. If you have high frequency loss already, you've been to a few too many concerts or things like that where there's a high frequency of loss, and a lot of older people do have that high frequency loss, then you're at about a 10 to potentially 15% chance of having a further decline. And that's why the hearing test and the audiology is so important. It doesn't happen all of a sudden, but it has this slow decline. So if we do an audiology after about 3 treatments or so of Tepezza and you start to see a decline, we often send you to a subspecialist. And then you really think about, well, should you stop the treatment? And then we've noticed if you stop that treatment at that time, there's often improvement of even that subtle decline. So it's a very, very real thing that happened because we didn't really expect it and no one was monitoring at the time. But now with good monitoring and really good control and watching a patient, you can usually eliminate those factors. But that's the whole history of putting it together.
The Lumify, you're always going to feel better when you use it because it constricts the blood vessels, so it always makes you look nice and white. It doesn't have as much rebound redness as Visine did in the past, but the problem is you kind of get hooked on it, and you go down this, slippery slope where you end up feeling you're dependent on it because you don't like the way your eyes look like when you're not using it. So I try and tell my patients, if you have a special occasion, absolutely go for it. But on a regular basis, I would rather have them control their dryness. There's so many new options for dry eyes, the lubrications, the lid hygiene, drop, different treatments, plugs. So Lumify, I like to reserve for special occasions.
That's a great question. So Dr. Douglas does do a lot of orbital decompression, which we do run through insurance. And yes, as long as it's medically necessary, insurance deems it as something that they will pay out on. It is under the policy to pay. Well, I always tell patients, try for every foundation program out there. I'm happy to share a list of different foundation programs, and I never know what they're going to cover. Actually, sometimes they'll cover your lights at your home. Sometimes they'll cover travel time to and from. So it's good. I have a list of about 7 or 8, and if you want to leave that message, I'd be happy to share that list with you. And that's a good place to start. And I say just enroll in all of them, and then see what comes back and see what they'll cover.
So it's always possible to stop Tepezza anytime. So I think that's one thing that patients should know is that, hey, if you're having a bunch of side effects, you're having hearing decline, you're having something that we would want to stop, then probably should stop. The problem with stopping Tepezza, if you're not having side effects, but you start to notice a really good improvement and you stop, is that there are some studies that show that may affect the durability of treatment. So it may mean that it's not quite as a durable treatment if you say stop after 4 infusions as opposed to stop after 8. Again, I hesitate to put this out as a rule because a lot of times I talk to patients. It kind of depends on their level of disease. If it's a reactivation, then I approach that a little differently. But in general, the 8 treatments typically do very well. We at least know very well from the 8 treatments that it maximizes their durability of response, the long-term, improvement, and and it typically works very well. And that can be modified to some degree, but it's certainly that's kind of the benchmark to start.
If I may add on to that, it can be challenging too if a patient stops mid-course for insurance to go ahead and cover the remaining course once they've stopped. So they might say that the patient's lost a follow-up and patient didn't complete their course. Now, if there's just a slight delay, a few months, I would say, but it has been challenging when patients come back, let's say a year later, and they want to resume their treatment, then insurance has given us some challenges on that front.
Selenium, the amount that was used in the study in the New England Journal, which was about 15 years ago, was I think 200 micrograms, and that is actually usually available in a multivitamin. But almost any health store, or including 3 Brazil nuts, will have that degree of selenium. That was primarily a European population that probably is selenium deficient, but it certainly can't hurt to have selenium. And I think it comes in the 200 microgram dosage at any nutrition store. hair loss is a little variable with Tepezza. So typically patients do know some hair loss with hypothyroidism. I'll let Dr. Agaveri talk about that too. The Tepezza hair loss is a little different. So most of my patients don't notice. It happens about 10% of the time, and usually it's not scalp hair where most patients notice it. It can be, but that is reversible. Most patients, or most of my patients, have noticed a loss of body hair, and they're a little freaked out by that at first. And then it absolutely does typically come in much less afterwards. It's not completely permanent, but it does have a decrease of the body hair. I've not seen really anyone have a significant decrease in eyebrows. And for men, some of the men have noticed that their beards are a little thinner, but that seems to return. Overall, most of my patients really do not get too upset about the hair loss, frankly, even though it's a really big problem because they've noticed it and they've had this issue from hypothyroidism. Maybe I'll let Dr. Agaveri talk about the hair loss of hypothyroidism.
Well, you can get hair loss and brittle hair from either hypothyroidism, Hashimoto's, or Graves' thyroid disease. So, and usually once you treat the disease and the thyroid function gets better, it takes about 6 months for the hair to catch up and get back to normal. So that's what I usually tell patients, just to be patient, and it usually does get better once you treat their thyroid disease.
Ideally, you want to use Tepezza in the active phase because you'll get more robust results. But I do have some patients that have been in the chronic phase for years, and we've still tried it, and we've still gotten a significant improvement. But ideally, if we have the option to treat in the active phase, that's what we would prefer. So with the Tepezza, you are improving a lot of the inflammation, but it's variable on how much improvement each person gets. So you might improve the bulging significantly, but then you still might have some bulging that might affect you. You know, some patients would like to still improve that. So a decompression would absolutely help with minimizing the additional bulging. In addition, the Tepezza, may not get rid of all the eyelid retraction where the eyes are too high, and so definitely we would want to do surgery for that. The Tepezza will improve the amount of fat and swelling around the eyes, but sometimes you still might want a blepharoplasty to remove the residual fat. And then lastly, if you still have double vision, you might still need muscle surgery. And we typically like to do them in a certain order after that, but you absolutely may still need surgery afterwards to fine-tune results.
The process, again, comes back to kind of individualizing it for patients. So an average patient, I give 3 options. One is that we can do nothing, and as long as they don't have vision-threatening disease, that's great. We can do a medical therapy and then surgical therapy, which often revolves around decompression or some surgery around the eyes or the orbit. And a lot of times patients will have Tepezza, and then 75% of them don't want any further surgery, but 25% do. And at that point, the oculoplastic surgeon is the person typically who would take them on the journey of an orbital decompression. And what that looks like is kind of talking about the realistic expectations of what an orbital decompression would entail and achieve. And that means looking at old photographs and saying, and thinking about, what the appearance would be. Also improvement of comfort and dryness of their eyes. And then at that point in time, you kind of decide how much of a decompression to do, because not all decompressions are the same. You can have, it's just like different size cars and trucks. They come in various sizes. So a small decompression could just be maybe removing a little bit of fat and maybe a little bit of the upper eyelid work. They're excited that they had Tepezza and they look better, but they want to even be a little bit better, such as Audrey was talking about. And then others are much bigger decompressions where you're going to do both sides at the same time, but you're going to get into the sinuses and everything. So, but it's really up to the oculoplastic surgeon and the patient to kind of decide the risk versus the benefit of that. And typically a decompression, if you do both sides, you can come in, go home that same day, usually about a 2-hour surgery, and then about a 2-week recovery where you're not bruised and swollen, and you can get back to exercising at that point in time, and then about a 3 to 6 month total recovery back to normal.
Is a CT scan always required before that?
About 90% of the time. If it's just removing a little bit of fat and it's really small, sometimes I don't get a CT scan, but ideally you probably do want to get a CT scan in the majority of cases. So that was a very big question because Tepezza was launched around COVID. So you can imagine that there was a lot of interest right around that time as far as what this does. So interfering with the IGF-1 receptor in Tepezza does not appear to in any way alter the immune system or the immune response. Tepezza was actually a previous drug, and these drugs were looked at in the cancer and oncology space 10 years prior, and there was no evidence of any kind of immune depression associated with Tepezza. So even a vaccination status, even as far as titers post-vaccination, all have been unaltered whether you're on Tepezza or not. You can even typically have surgery while you're on Tepezza, say you need a thyroidectomy, etc. Doesn't appear to be any untoward effect as far as healing either. So the thyroid levels were measured really extensively during testing. And in fact, one of the criteria for the initial trials was that your thyroid levels had to be within a relatively normal range, because sometimes, as Dr. Ekberg was saying, sometimes if you improve the thyroid levels, the eyes get a little bit better. So you didn't want that to be a confounding variable. But what's been shown is that Tepezza does not appear to significantly, at least in 98% of patients, to significantly alter their thyroid levels. So it pretty much leaves them the same. Probably, but it hasn't really been as publicized or released, it probably decreases the TSIs over time, significantly, but that's been a little less published on. But by and large, they're two separate processes. I've only had 1 or 2 patients in the entire 400 that I've treated with Tepezza that actually had an appreciable thyroid hormonal change and had to have their medication altered. We just really want to thank everyone for attending today, and really appreciate any feedback that you offer for us and moving forward. So have a wonderful day. Thank you.